Good morning. I am Dr. Shivakumar from the Pediatric Cardiology Division of Madras Medical Mission Hospital. Today we have an interesting patient who needs a reconstruction of the right ventricular outflow tract.
Today's case is a 18-year-old boy with tetralogy of Fallot. He underwent initial corrective surgery at 4 months of age where the VSD was surgically closed and the RVOT was reconstructed using a transannular patch. At 1 year of age, he was identified to have LPA origin stenosis and he was taken for cardiac catheterization. The first angiogram shows the significant LPA origin narrowing. An initial balloon dilatation was attempted which caused recoil, so he was planned for stenting. The second angiogram shows stenting of the LPA using a Genesis XT2910 stent. We can see in the third image that after deploying, the stent migrated into the MPA. On manipulation, the stent got advanced into the right pulmonary artery, which was held with the balloon initially and pulled backwards toward the RVOT. And in the third image, you can see that the stent has been held using a 25 tie-shuck soft balloon and it has been pulled in the RVOT proximally and fixed there to prevent further issues. And he was doing well after that. The LPA origin was having mild LPA narrowing because of the significant dilatation done with the balloon and also during stenting. He was having free pulmonary regurgitation and mild LPA origin narrowing and he was on follow-up. He had gradual dilatation of right ventricle with NYHA class 2 dyspnea now. And this is the ECG at present, which shows sinus rhythm with the complete right bundle branch block with the QRS, which is quite prolonged, which is 160 milliseconds, which is one of the indications for a percutaneous pulmonary valve implantation in a patient with moderate to severe pulmonary regurgitation. And this is the X-ray, which shows moderate kyphoscoliosis. It's RV apex with the dilated main pulmonary artery, and we can see the stent there. This is the echo, which clearly shows that the RV is significantly dilated when compared to the left ventricle, and the MPA is dilated, and the RVOT, which had a proximal stent, is fixed and it is not dilated and it is narrow when compared to distal MPA and proximal RVOT. The third angiogram shows the to and fro flows with a gradient of 42 millimeter of mercury across the stent. This is a CT which we did, which also showed that the LPA having significant narrowing with the origin of 6 into 5 millimeter and a hilum was measuring 18 and the length of the LPA was around 3 centimeters. The stent in the proximal RVOT was measuring 17 into 17 millimeter in its internal diameter, and we can see the dilated MPA distally and the proximal RVOT and the RV which is dilated. So this is the restriction in this patient at present. So we did a volume rendering and virtual reality. Here we can see that this is the narrow portion with the dilated MPA and this is the stent going posteriorly. Now we can see the LPA origin also, which is quite significantly narrowed and it is arising at an angle. When we see the hollow heart model, it again shows the dilated RV, the stent which is causing a restriction there, the dilated the MPA is significantly dilated, and then when I go more posteriorly, we can see the LPA origin now. The LPA origin which is significantly narrowed and the LPA hilum which is reasonably good in size. So the plan is to stent the LPA. So if we stent the LPA virtually, we can see that the stent in the LPA is quite far compared to the proximal stent where we have to redilate and should do melody valve implantation. So this should not affect the procedure that is done in the proximal stent and the pulmonary valve.
That was an excellent volume rendering on the immersive platform that you have done to give sort of a virtual reality, as if we have opened the right ventricular outflow tract and the main pulmonary artery and you are showing the landing zone very clearly. That was a lovely image. So as you had specified the strategy here, we have to set right the left pulmonary artery narrowing so that we have a good amount of blood flow to the left lung, and then we have to put in a competent valve on the right ventricular outflow tract. The previous stent that has been placed across the pulmonary annulus is currently measuring around 18 millimeter, and in order to give the optimal hemodynamics, probably we need to widen it to around 22 millimeters. As you know, the Genesis XD is a cell that significantly foreshortens as you dilate larger and larger. I had done the right heart hemodynamics. The right atrial pressure was around 8 millimeters of mercury. The right ventricle was around 40 millimeters of mercury and the pulmonary artery was 30/5. The low diastolic pressures were indicative of free severe pulmonary regurgitation, and as you showed pictures, the RV was significantly dilated. I am positioning myself for a couple of angiogram to delineate the left pulmonary artery origin. We had already seen that the main pulmonary artery was aneurysmally dilated, and so it's likely that LPA origin will become hidden. So let me start with the epicaudal view to separate the main pulmonary artery from the left pulmonary artery. Yeah, we are just able to see the left pulmonary artery. However, the origin is not so clearly getting delineated. We realize that this is going to be a challenge. So let me also try out one picture, maximum cranial. Can we go to the cranial? Okay, this is marginally better. I'm able to see the left pulmonary artery just coming out of the main pulmonary artery. So the plan will be to get a stent of the origin of the left pulmonary artery and the mediastinal part of the left pulmonary artery. Dr. Pramod, you mentioned that the hilar part of the left pulmonary artery was as big as 18 millimeter in the maximally dilated projection. So let us target an 18 millimeter stent. Let's try to go as deep as possible. I will exchange that ambulance superstiff with a 6 French guide catheter, which will allow a second guide wire. The problem about using directly a Lunderquist will be, since I'm finding that the entry into the right heart is a little bit
Center.
tortuous, my Lunderquist may push out the entire catheter. So first I will stabilize it with an Amplatz superstiff guide wire. And this Amplatz superstiff guide wire now will allow 6 French RCA right coronary guide catheter.
Sir, you
Can I
explain
get,
why are you not using Amplatzer alone for Amplatzer super stiff alone for doing the procedure and want Lunderquist wire?
basically, I want to park a 12 French sheath, a 12 French braided sheath. It's going to be quite a bulky device to go through. So if I have a much more stiffer guide wire, it's going to make the procedure a little bit more simpler. With this position, I'm now getting ready for a 12 French long flexor sheath, which will be parked across the left pulmonary artery. Now we will try to get a short 14 French dilator to dilate the groin sheath. So this step will make it a little easier for the 12 French sheath to pass through. So now we have a 12 French long braided flexor sheath. So as you are holding it, trying to advance. So the dilator has already passed. Can you
Center the table.
So I'm advancing the sheath over the dilator. I've gone reasonably deeper. So I am taking out.
We can see that this is a braided sheet, sir. What are the other braided sheets you would suggest that can be used as
Well,
an alternative?
it depends on the country where you are living. I think the New Med Corporation makes a sheath called devil sheets, which are quite useful sheets. They are also braided, they are quite flexible. And then the Termo in Japan makes destination sheets. We, in our part of the world, we get the Cook flexor sheets, which are the braided sheets. The Medtronic has got a long sheath called as the Stent sheath. The different countries have different sheaths that are available. So let us now concentrate on the stenting. Is now going to take cobalt chromium stent of 29 millimeters long. This particular cobalt chromium stent cell design, I'll show the stent now. This stent doesn't foreshorten. So it's a 3 centimeter long stent with 6 zig elements that you can see. The proximal end and the distal end are closed cell design, and the mid design is open cell. It doesn't foreshorten, and that is a significant advantage. Slowly advancing. I'm advancing in small pushes so that if there is any tension that is mounting on the wire, it will recoil back. I'm reaching the target of the left pulmonary artery. And we realized that the best picture was epicranial. Can you run that epicranial picture again? I can see the endotracheal tube. And can you freeze it? If I draw a line from the endotracheal tube, it was the left pulmonary artery origin is almost, can you, one frame before? Yeah, I think the LPA origin is in line with the endotracheal tube. So let me see. Yeah, we are around that area. I'll advance the stent a little bit more. Can you hold the wire so that I'm advancing?
Yeah, I think it went in.
And okay, at this point, again another picture. The position looks fine because we're able to see that discrete stenosis. Can you give one mag here? Zoom that. Yeah, position it now. I think that discrete LPA narrowing at the origin, we are positioned well.
Yes, sir.
So if I am able to peel back the sheath, you are ready for an inflation, correct?
Yes, sir.
So I'm just going to peel back the sheath. At this point, one more angiography. It looks fine. Okay. You can start blowing the balloon.
Inflating.
Yep.
I'm inflating the balloon.
Yeah.
This should be.
Yeah. Keep inflating. Keep inflating. Keep inflating. Keep inflating. Keep inflating. Yeah.
I'm going to 4, 6,
Yeah.
6,
Yeah.
6, and 7.
7. Go to 7. A little more than 7.
7,
Okay.
8.
Okay. Now deflate the balloon. Fine. The distal part, which was the healthier part, is looking expanded more. The origin, which was the narrow portion, is having lesser expansion. However, the lumen is quite broad. Let me see. It looks fine, right? So now let us gently take out this balloon out. We'll try to dilate now the main pulmonary artery stent to a diameter of initially 20 followed by 22. I will also make this an opportunity to study the left coronary artery. You can go into the coronary picture. The coronary seems to be far away. Can we get one caudal view? And make the main pulmonary artery stent come like a circle. Yeah, go elevo. Correct. More caudal. Yes, correct. So the main pulmonary artery stent is becoming like a circle. And at this point, I'm giving one left coronary. So the left coronary artery is far away from the stent. And hence, I think there is no major concern about coronary is getting squeezed by expanding this main pulmonary artery stent.
So what are the balloons you prefer for post dilatation in these kind of cases, sir?
Okay.
Other than this
Can we get the main pulmonary artery stent, please? The one of the balloon that is commonly used around the world is Atlas. And Atlas has got two versions, Atlas Gold and the regular Atlas. Atlas Gold has got a shorter taper. This is one balloon that goes up to around 16 to 18 atmospheres. The second balloon is the true balloon. And the third one is the nucleus balloon. All these three are very high pressure balloons available in the larger dimensions. Right now, as I'm inflating the balloon, Uday, the patient may get into hypotension. Okay, yeah, keep inflating. Yeah, yeah, yeah. Go.
I'm inflating to 2, 4, 4, 6.
Yeah, keep inflating, keep inflating.
6,
Yeah,
6,
yeah,
8, 10,
yeah. I'm finding
10,
that it is significantly
11,
shorter.
12,
Yeah, yeah,
12,
yeah,
12,
yeah.
12, 13,
Yes.
14.
14.
14.
Okay, 14. Little bit more. Little bit more.
Yeah, 14.
Okay. Now we can deflate. There is a significant hypotension as expected because we are completely occluding the right ventricular outflow tract. I am deflating the balloon faster. Compared to the Atlas balloon, the Atlas Gold has got a little smaller volume because of the smaller taper. And so it deflates a little bit faster. Now we have got back the pressure. There is some increase in the size of the stent. Can't you see that, Uday?
Yes.
Yeah. So I'm taking this out and I'm now changing it into a 22. We have sufficient volume.
The volume looks adequate.
Adequate. So, okay. So, Vishnu, you are positioning the, yeah. So, I will just get the balloon a little bit below. Yeah. Yes, Pramod.
Yes.
You go for,
going to,
yeah, go to 14 atmospheres.
2, 2, 2, 4, 6, 8, 10, 12, 12, 12, 13, 14.
That's enough, I think.
Yeah.
Okay, we have significantly foreshortened. We can deflate now. The blood pressure is very low because of the full inflation. The blood pressure has picked up back. Let's get one angiogram done. I want the pigtail catheter, 6 French with thermo guide wire. I'll go parallel to this. So this is our landing part. Okay. So we have seen maybe you can make a measurement, Prabhu, on this. So I'm going to take out this pigtail catheter out. I'm going to introduce a 2 ml syringe. And as I am loading it, I'm elongating the stent. It's a 34 millimeter CP stent. And when it is fully expanded, it almost shortens down to 27 millimeter. So now what we are doing is that we are trying to make the 27 millimeter back again to 34 millimeter. So I am elongating it. Also, the blue color indicates the pulmonary end. The white color indicates the ventricular end. So I have introduced the syringe after fully opening the valve from the pulmonary end into the ventricular end. So that now when I am pulling along the line of the valve itself. So the next step will be, I'm going to take it onto the melody valve. I am loading it onto the ensemble system. This is a 22 millimeter ensemble system. I am matching the blue to blue and white to white. So now the ensemble 22 system is now getting inside the 24 French short introducer sheath that has been placed. So now I'm advancing. That is the melody, the ensemble system that is coming up.
You can zoom out.
Zoom out. So we have positioned it in the middle. Now let us come to AP itself. Yeah. Make the stent come in profile. So now I am exposing the sleeve of the melody valve. So now I have got the sleeve out totally. We can inflate the inner balloon. The inner balloon's burst pressure is around 4 atmospheres. Yeah, so let us go to 4.5.
Okay, I'm inflating now.
Yep.
Going to 2, 3, 3, and 4.
Full 4.
4.
And
Yeah,
then we
fully
can lock
4.
it. So the positioning is fine. You are inflating the balloon. I'll just position it. Yeah, we can now go in.
I'm going with the outer balloon now.
Yep.
The outer balloon is going at 1,
Yeah.
2,
Yeah.
2,
Yeah.
3,
Yes.
4.
Yeah.
Yeah, 3.
Is it 3?
I'm going up to 3.
Okay.
Yeah,
So go
3.
up to 3. Okay.
3.
Okay. Now, fluorostore. Okay. Now I'm taking a shots in it. Deflate now. The cardiac output is stopped because of the deflate fully.
Deflated.
Fully deflate. And let me deflate the inner balloon also. This is fully deflated.
This fully deflated.
Okay. The pressure is picking up. Can we also see an echocardiogram now so that we can visualize the valve and see how the valve is functioning? Yeah, the tricuspid valve is quite good. As a mild tricuspid regurgitation. Can you Doppler the tricuspid regurgitation? So the RV systolic pressure now is about 30 plus right atrium. And let us see now the right ventricular and left ventricular contractility. RV looks smaller, not very dilated. The left ventricle is also looking normal. Okay, mitral valve is having a trivial leak. Aortic valve is having a trivial leak. There is no residual VSD. The VSD patch is seen here. We can see that there is a trickle of leak that is seen in the pulmonary valve. We are able to now see the melody valve. There is a trivial central leak as well as a trivial leak that's just seen outside. It's not clinically relevant, but Doppler is able to pick it up. So the small paravalvular leak is anterior. And we are able to see the central leak as well. The overall, the right ventricular function is looking good. So, so today what we saw was left pulmonary artery stent angioplasty. The previously placed main pulmonary artery stent was used as the landing zone for the melody valve, and the left pulmonary artery has been dilated now with using an 18-millimeter balloon. And yeah, good result. Reasonably satisfied with the results. So I would probably say that. Thank you for the opportunity.